we can begin. Okay, so welcome everyone to the Department of Surgery rounds. It gives me great pleasure to introduce the George Armstrong Peters and the Lister Prize winning award presentations today. You can see from my backdrop, just as a reminder, that's what the Department of Surgery looks like. Eventually we'll get back there and we'll all have an opportunity to convene together in the Department of Surgery spaces. But for the moment, that's a virtual background. And typically with these presentations, we begin with the Lister, we begin with the George Armstrong Peters Award and move to the Listers. But today we're going to do it in the reverse order because the Lister Award winner, who is Dr. Subodh Verma, is having an award-winning day, and he has an award presentation he has to attend right at 8 o'clock for the Horsey Award, I think it is, at St. Michael's Hospital. So double congratulations to you, Subodh. I just want to begin at first with a land acknowledgement, and here you can read with me on the basis of our opening of today's lecture. So we wish to acknowledge this land on which the University of Toronto operates for thousands of years. It has been the traditional land of the Huron-Wendat, the Seneca, and most recently the Mississaugas of the Credit River. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Our treaty obligations and commitment include learning about the history of these lands and territory and the structured dispossession that Indigenous nations have been subject to by Canada, and learning about justice, equity, structures of power, and to imagine how we can build social relations together for a different world. We affirm our solidarity with the Indigenous peoples of this land struggling for their self-determination and sovereignty from settler colonialism. Okay, with that introduction and land acknowledgement, the Joseph Lister Award is given to a senior member in the Department of Surgery who has accomplished great things in the field of research throughout her or his career. The previous award winners are listed here, and you can see it's a real who's who in the Department of Surgery across all the divisions within the Department of Surgery, going back to 1980. Joseph Lister, you'll recall, the founder of Antisepsis, plays a big role in the Department of Surgery. We have a plaque. We also have a portrait of Joseph Lister in the Department of Surgery office. You remember last year, the 2021 Kurgan Lecture was all about the brutal world of Victorian surgery, and it was a review of the book written by Lindsay Fitzharris called The Butchering Art, all about Joseph Lister. Okay, now all about Subodh Verma. Subodh received his master's and PhD from the University of British Columbia. In 2000, he got his MD from the University of Calgary, residency in cardiac surgery at the University of Toronto. In 2007 and 12, Canada Research Chair in atherosclerosis at the University of Toronto, Canada's top 40 under 40 in 2010, over 500 peer-reviewed publications in big journals with high impact. You can see New England Journal, Circulation, JAMA, and so many others. Grant support from numerous peer-reviewed agencies, NIH, CIHR, Heart and Stroke, and many, many others. I've asked each of the award-winning presenters today to provide me with a backdrop photograph from their family, and this one is from Subodh's family. So Sandra, his wife, Raj, who's 17, Sonia, who's 6, and Mina, who's 14. This is taken at graduation at Crescent School recently. A great camera, great photograph. So Subodh, with that introduction, we'll ask you to take over the screen and tell us about your career research presentation at the heart of diabetes. Okay, Subodh, over to you.
Well, thank you, Dr. Rutka, for those very kind words of introduction. It's really my great privilege to be the 2021 Lister Award recipient. I'm deeply indebted to you, to the Department of Surgery, to my wonderful colleagues, Dr. David Latter, Dr. Ori Rodstein, who I believe now were instrumental in catalyzing the nomination for this award. And I'm eternally grateful to be part of such a wonderful university and a wonderful department. I've had 4 dominant themes or programmatic interests from a research standpoint in the area of atherosclerosis, diabetes, heart failure, clinical trials in cardiovascular surgery. And we've tried to address these themes through the lens of basic and translational physiology, pharmacology, through the development of the Cardiolink randomized translational clinical trial platform at St. Michael's Hospital, through the conduct of large clinical trials, which in turn have affected and impacted on clinical practice guidelines. But I'm going to tell you my story around one of those themes today, and that is the theme of diabetes. I had the great privilege of being mentored by a wonderful individual, Professor John H. McNeil, who was the Dean of Pharmacy at the University of British Columbia. And I think, was his 51st or 52nd graduate student. Turns out my father was his first graduate student. And in 1994, I published my first paper on the effects of metformin on isolated structure and function in diabetic rat hearts. So I've had a long-standing affair, if I may, with diabetes, and that has really continued throughout one of the programmatic themes that we've been working on. As you know, diabetes remains a recalcitrant problem which is growing globally. It is expected that by 2030, close to 750 million individuals will have type 2 diabetes. We know that diabetes leads to several complications, specifically at the level of the pump, i.e. heart failure, at the level of the pipes, i.e. atherosclerotic events, and at the level of the filter, i.e. renal disease. And the effects of diabetes on the pump, pipes, and filter are a dominant mechanism through which cardiovascular complications, morbidity, and mortality occurs in this population. And we've really had an interest around all three of these axes from a basic translational and clinical trial standpoint. From a basic and translational standpoint, we've had a lot of interest in the pathophysiology of atherosclerosis and diabetes. And early on, working with my mentors, Richard Weisel, Renki Lee, Terry Yao, and others when I was a resident, we actually developed and described this entirely novel concept of a crosstalk between adipocyte-derived cytokines, also called adipokines, and how these hormones released from the adipose tissue were not only important in the genesis of obesity, but also spilled over into the circulation and actually were critically important in vascular homeostasis. Through a bunch of carefully described experiments, we really outlined the molecular mechanisms through which many of these adipocyte-derived cytokines impacted on vascular health and endothelial function and inflammation, and really entered, and these data were critical in really establishing a new vernacular with respect to how we thought about adipocyte-derived cytokines as being key markers and partakers in the process of endothelial activation, not only in atherosclerosis, but those data have now been expanded such that these adipocytokines are now believed to be critical regulators of sepsis-related vascular injury as well. Dating back to when I was a resident working with Dr. Weisel and Terry Yao and Vivek Rao, we described in the human microvasculature the effects of diabetes and how diabetes in human microvessels was associated with an increased production of endothelin-1, and how endothelin receptor blockade was associated with a reversal of the endothelial dysfunction phenotype triggered in human microvessels from patients undergoing bypass surgery. We then moved on to looking at autophagy for several years, and we still have an interest in autophagy. As many of you know, autophagy is a highly regulated internal processing pathway through which organelles are recycled and efficiency in cells is improved. And we were really lucky to get into this field at a time when the impact of autophagy on vascular health and diabetes was not really well understood. And through a series of experiments that included endothelial specific knockout of key autophagy genes, we described an entirely novel paradigm through which autophagy dysregulation was a critical regulator of aberrant vascular hemostasis or homeostasis in experimental settings of diabetes. In and around that time, we were also developing an interest in understanding how the bone marrow reparative response was important in atherosclerosis, in states of cardiometabolic risk and in states of diabetes. And in this work, as you see, co-authored with our current chair, Dr. Terry Yao and Bill Stanford and others, we described how the stem cell factor c-KIT axis was critically important in aberrant vascular remodeling, particularly in states of atherothrombosis and diabetes. And on the right, described a novel paradigm wherein in experimental models of diabetes, we were able to demonstrate an impaired angiogenic progenitor cell differentiation towards the endothelial lineage, really outlining abnormalities with respect to bone marrow vascular trafficking. Now, that was all work done in experimental models, but over the last 5 years or so, we've really focused our attention to humans and translational studies from a physiology and pharmacological standpoint, and really coined this term RCE, or regenerative cell exhaustion in humans, through a series of elegant studies in collaboration with Dr. David Hess and Dr. Ori Rodstein and several graduate students listed here. We've described this concept that in humans with type 2 diabetes, there is really this phenotype of RCE, or regenerative cell exhaustion, which is characterized by reduction in proangiogenic progenitor cells, a reduction in monocytes with M2 phenotype, an increase in inflammatory granulocytes, and resultantly a low capacity for vascular regeneration. So the first human description really of an abnormal bone marrow reparative response in people with diabetes. Now, what about therapies to improve vascular function in diabetes? And again, early on, some of my postdoctoral work at the University of Calgary with Todd Anderson was a description that treatment of patients with diabetes with metformin was associated with an improvement in endothelial function as assessed in the forearm. And subsequent to that, we have now focused our attention on many other strategies, anti-hyperglycemic and others, to improve vascular function and regenerative cell exhaustion in people with diabetes. And in this recent publication, the demonstration in a randomized control translational study that the anti-hyperglycemic agent empagliflozin really restored regenerative cell exhaustion in people with type 2 diabetes who had established cardiovascular disease over a 6-month treatment period. I've really had a lot of excitement working with Ori Rodstein and Stephen Glazier and David Hess and others, where we have tried to address the cardiometabolic phenotype in humans undergoing bariatric surgery. And as you know, bariatric surgery is associated with quite a profound weight loss, but also a profound cardiovascular benefit. Whether that actually is it translates into changes in regenerative cell phenotype was unknown. So in this study, which was incredibly difficult to do, we found that bariatric surgery associated weight loss actually was associated with a real restoration of this reparative regenerative phenotype in people with and without diabetes. Now, what about other pharmacological strategies in people with diabetes to improve cardiovascular outcomes? And in this paper that has just been published this week in Circulation Online, we've looked at the about 2,000 patients with diabetes who have a history of prior CABG, demonstrating that icosapent ethyl, a highly purified omega-3 fatty acid, was associated with a 24% relative risk reduction in cardiovascular events and revascularization in this population. We've also carefully evaluated other strategies, particularly DPI or dual pathway inhibition with rivaroxaban and aspirin, and demonstrated again that people with diabetes tend to derive a greater absolute risk reduction from dual pathway inhibition from a cardiovascular standpoint. And these are data from the large COMPASS trial. I've had a really long-standing interest in the GLP-1 RA class of medications, These are medications, as you know, that are now class 1 indications for people with diabetes and vascular disease. And in the LEADER trial of about 10,000 patients, we demonstrated a profound effect of liraglutide in people with diabetes with and without established cardiovascular disease to reduce major adverse cardiovascular events. And in a sister publication, we also described that the greatest benefit of this GLP-1RA in people with diabetes appeared to be seen in people with a prior history of an ischemic event, whether it's a myocardial infarction or stroke. And that has led us to really develop this very large clinical trial called the SELECT trial that is now fully enrolled of 17,500 patients, in which we are asking the question of whether the GLP-1RA semaglutide could have a cardiovascular benefit in people without diabetes who have obesity. During this journey, it became apparent that risk stratifying people with type 2 diabetes was important. And one simple way of risk stratifying these patients was to just count how many arterial beds were involved in terms of atherosclerosis. And it became pretty clear early on that people who have diabetes and polyvascular disease, i.e. disease in more than one arterial bed, actually seem to have a very high placebo event rate for cardiovascular events. And that has really carried forward as a way to risk stratifying patients with diabetes and identifying the highest risk people who can derive benefit from risk reduction approaches. As many of you know, one of the dominant interests in our group is inflammation, and working with Michael Farku and others, we've tried to evaluate whether inflammation plays a primordial role in the pathophysiology of atherosclerosis in diabetes. And one simple way that we thought would be useful to address this question was to use a really non-specific anti-inflammatory strategy such as methotrexate. And I was really, really grateful to be part of the steering committee of the CERT trial, where we took about 5,000 patients with diabetes and vascular disease. We treated them with methotrexate, low-dose methotrexate. But as you can see here, not all hypotheses turn out the way you want them to. We actually found an entirely neutral result of methotrexate on cardiovascular outcomes. And we started thinking whether a more specific strategy was required. And in fact, canakinumab, that was studied as a really selective inhibitor of interleukin-1 beta, the product of the NLRP3 inflammasome, seemed to actually at one dose yield a positive outcome with respect to reduction in MACE events in people with atherosclerotic vascular disease. It really ushered in a new calculus of thinking about inflammation targeting as a strategy to reduce cardiovascular outcomes in people with diabetes. And I'm delighted to say that we've just embarked, and just the first few patients have been now randomized into the ZEUS trial, which will evaluate ziltivekimab versus placebo, a selective IL-6 inhibitor, as a strategy for secondary prevention in people with diabetes and vascular disease. We've also had a long-standing interest in heart failure as it relates to cardiometabolic risk, and just this week, we have published the largest analyses from 3 cohorts describing the prevalence and prognostic implications of diabetic cardiomyopathy as evaluated with echocardiography and natriuretic peptides, and defined the presence, prevalence, and its prognostic role as it relates to measures of diastolic dysfunction. I think a lot of us think about diastolic dysfunction in diabetes. We think about diabetic cardiomyopathy, but the real gravitas of this problem has not been previously carefully characterized, and that is what has been done in this paper. But I think one of the greatest excitements that I've had over the last 5 years has been this real serendipitous story of Sgld2 inhibitors. Who would have thought that a drug that was actually supposed to just lower sugar by causing glucoseuria, by interfering with glucose reabsorption in the proximal tubule, would be a transformative and formidable strategy for heart failure. And in fact, as many of you know, Sgld2 inhibitors have been shown to reduce cardiovascular death and hospitalizations for heart failure. And in fact, in people with a history of CABG, we've shown almost a 50% reduction in CV death and heart failure hospitalizations in such patients. There's also been a dominant benefit of SGLT2 inhibitors on renal protection in the order of 40 to 50%. And again, it came out of left field. Nobody really thought that these glucose-lowering drugs would be strategies to prevent and treat heart failure and renal disease. Now, there was a lot written about the ability of SGLT2 inhibitors to prevent heart failure and diabetes, but there was two open questions. Can these drugs treat established heart failure with and without reduced or preserved ejection fraction? And what if these drugs were actually drugs to treat heart failure even in people without diabetes? And in that regard, we embarked on 4 large clinical trials. And again, it's been my distinct privilege to be part of all 4 of those stories. The DAPA-HF and the EMPEROR-reduced trials that looked at patients with dapagliflozin, empagliflozin in people with a reduced ejection fraction, with or without diabetes. And in these 2 publications in 2019 and 2020, as part of this large steering committee, we demonstrated for really a novel paradigm, a really exciting paradigm that in people with and without diabetes who have heart failure and a reduced ejection fraction, that these drugs cut on top of standard of care the outcome of cardiovascular death and heart failure by 25%. In fact, the data were so remarkably consistent that it's led to editorials, 2 tales, 1 story, that it's not about the drug, it's about the class of medications. And it's also led to various mavens in the world, as you can see here, my Professor Eugene Brownwell from Harvard Medical School and others calling it a big victory in the war against heart failure, which, as you know, remains a growing and burgeoning problem worldwide. It also introduced an entirely novel concept. No matter what kind of doctor or surgeon we all see patients with heart failure, and we know that they're standard therapies, and to those standard therapies, these data added a new foundational pillar, and that is the use of SGLT2 inhibitors to reduce mortality. Now, one of the intriguing questions, which, going into these trials remained unknown, was could these drugs really be treatments for heart failure in people without diabetes? Would SGLT2 inhibitors, diabetes drugs, have benefits beyond diabetes? And Mark Petrie and I led this analysis published in JAMA last year, where we described from the DAPA-HF trial an entirely consistent benefit of dapagliflozin across the spectrum of A1C, providing the first and unequivocal proof that these agents work to treat heart failure in a fashion that is entirely independent of glycemic status, and introduced a new paradigm that these drugs may actually be beneficial to treat heart failure even in people without diabetes. Now, next week this publication will be released. It's actually now demonstrating the efficacy of empagliflozin in HFrEF in the EMPEROR-reduced trial on top of standard of care, on top of standard of care doses, and on top of standard of care combinations. Really introducing this concept that these drugs are entirely complementary. For some of our junior trainees on the line, teamwork really does pay off. There's been about 25 sub-analyses from the DAPA-HF trial, a similar number from the EMPEROR-reduced trial, and it's been a wonderful way of collaborating with global colleagues over the last several years. But what I'm really excited about is that those contributions have changed the clinical practice guidelines in Canada and worldwide. These 2 trials have now introduced an entirely novel standard of care where SGLT2 inhibitors are now standard therapies in patients with HFrEF in Canada and class 1 indications in Europe. Now, what about heart failure that is worsening heart failure in terms of, patients not just in the ambulatory setting, but patients who are hospitalized with a worsening heart failure event? And we did a trial called Soloist, where actually we demonstrated that those patients admitted to hospital with worsening heart failure also derived a 33% benefit with the SGLT2, SGLT1 inhibitor. Now, if that was not sufficient excitement for me and the team, we started asking the question about what about HFpEF? Again, this has remained a enigma for years because no therapy has ever met the primary outcome in HFpEF, yet 50% of heart failure is HFpEF. So in the Emperor Preserve trial, we asked this question, a very difficult trial to complete through COVID, and just last month published the results of this large trial of about 6,000 patients with HFpEF, where we demonstrated a 21% relative risk reduction for CV death and heart failure hospitalizations in patients with heart failure and a preserved ejection fraction. And really this has again ushered in a new paradigm for HFpEF, the first strategy pharmacologically to then be shown to have a benefit in this population. We're working on a sister trial called Deliver, which we hope to report next year. Our group has also had a dominant interest in trying to figure out how at the bench and translationally these drugs work. And I've been really fortunate to work with numerous graduate students, numerous cardiology colleagues, numerous nephrology colleagues, and address this question very carefully from a bench to bedside perspective. In fact, we did the first randomized controlled trial from a translational standpoint that evaluated the effects of empagliflozin in patients with type 2 diabetes using cardiac MRI. And this was co-led by Dr. David Mazer and Dr. Kim Connolly, where we showed that over 6 months, these drugs actually facilitated cardiac reverse remodeling with a reduction in left ventricular mass index, an important surrogate of cardiovascular events. Dr. David Mazer from our group at our hospital also evaluated the efficacy of these drugs to increase erythropoietin, demonstrating that within a month of treatment, the drugs increase EPO production, which is an important mechanism through which heart failure benefits would ensue. Working at the bench, we evaluated whether these drugs change myocardial energetics and evaluated whether ATP generation from glucose, ketones, fatty acid oxidation, or glycolysis could be modulated, and demonstrated a 30% increase in ATP production in isolated working hearts in that regard. We're now working on the EMPA-Heart-2 Cardiolink 7 trial with Kim Connolly and Dr. Mazer, where we're actually studying this effect in people without diabetes. Given the dominant benefits of Sgld2 inhibitors on endothelial function, heart failure, vascular biology, renal function, we hypothesize that these drugs may actually be beneficial in the context of COVID-19. So as part of a steering committee, we actually did a trial of about 1,000 patients with hospitalized COVID-19, showed that the benefit was the therapy was entirely safe. You can see that the primary outcome showed a hazard ratio of 0.80, but didn't really meet statistical significance, likely because it was underpowered. But this has led to a whole new sort of line of thinking that the NIH and others are supporting now about whether these drugs could be therapies for sepsis in general and sepsis-related mortality. Lastly, what about revascularization choices in diabetes? And many years ago, after Dr. Michael Farku and Valentin Fuster published the results of Freedom, there still was equipoise with respect to CABG versus PCI in people with diabetes as it related to mortality. And along with many of the co-authors listed here, we published the meta-analyses that demonstrated a superiority on mortality, a 33% mortality benefit in patients with diabetes and multivessel disease in favor of CABG. And that really was the impetus to change the 2014 guidelines in favor of CABG versus PCI in this context. I don't have time today to tell you about Cardiolink, but it has been one of the most exciting research efforts that I've been involved in with great friends and collaborators listed on this slide, where we embarked on 9 randomized translational studies, thanks to Ori Rothstein and Art Slutsky and Mohammed Mamdani for giving us the opportunity to develop this a priori at St. Michael's Hospital. 6 of these trials have been completed in the sphere of atrial fibrillation and mitral valve repair, aortic surgery. And 4 of these trials are actually currently ongoing, and it's been a really wonderful way to collaborate with people throughout the world. What can I say? I've been just deeply blessed with a wonderful family. You know, I don't know why and how they put up with me, but they do. It's been the joy of my life, and thanks for sharing that slide. My deepest friends shown here, David Mazer, Adrian Kwan, Hui Teal, who I work with day in and day out, who make life so much fun. I'm deeply indebted to you, to my wonderful surgical partners. What a tremendous dynamic leader. I don't know why he wants to step down, because I don't think anybody can fill his shoes, Dave. But thanks to all of you for always being so accommodating. My 2 wonderful collaborators and dear friends, Larry Leader and Deepak Bhatt, and the many, many more people throughout the country and globally that I've had the great privilege of working with. Of course, the funding agencies and the Canada Research Chairs Program that was kind enough to not only award me a Tier 2, but also Tier 1 chair. So with that, back to you, Jim. It's been a remarkable journey, and thanks for your leadership, and thanks for this wonderful opportunity today.
Great. Thanks very much, Subodh. I really enjoyed your presentation. Congratulations on the topic, diabetes in the heart. It was clear to me that you've been collaborating not only at St. Michael's, but across all the different departments at the University of Toronto and well beyond that. The story about polyvascular disease and the drugs that you've selected, truly remarkable. Any one of us would give our eye teeth, I think, to have one New England Journal of Medicine publication, and you've got enough to support the entire Department of Surgery. So congratulations to you, Subodh, on a wonderful presentation. And congratulations on the next award you're about to receive too. So I know you have to leave the line to pick up your teaching award at St. Michael's. And this gives me an opportunity then to move on to the George Armstrong Peters Prize Award presentation. And this will be given today by Kristen Davidge. And the George Armstrong Peters Prize is given in honor of George Armstrong Peters. He's one of the most prominent surgeons in the Department of Surgery dating back to the beginning of the last century. The previous awardees are listed here, and the award goes all the way back to 1912 that you can see here. Again, to a junior faculty member, usually within the first 5 years of their practice. And this year, I'm delighted to announce the winner is Kristen Davidge. She received her MD at the University of Toronto in 2005, residency in plastic surgery, 2012. She did a fellowship at Washington University with Susan McKinnon, who's a former graduate of the University of Toronto Department of Surgery program. She received the Bernard Langer Surgeon Scientist Award 2019. She's been the program chair of the American Society of Peripheral Nerve, has over 50 peer-reviewed publications and grant support from numerous peer-reviewed agencies. Here's Kristen receiving her continuing appointment review in the Department of Surgery. There's Dr. Drake and Dr. Forrest in the picture. And the photograph that Kristen sent to me was interesting because she said because of COVID and the restrictions and so on, she didn't quite get a chance to have the whole family together in one photograph. So they sent two photographs, one of Neil and Kristen, you see on the left-hand side, and their daughters, Emma, age 8, and Vivian, age 5, just before Halloween. So with that introduction, I'll turn it over to Kristen, who's going to talk to us about the story of pain in children with brachial plexus birth injuries. Kristen, over to you.
Thank you very much, Dr. Rutka. Let me just share my screen. And of course, I was incredibly honored to receive this award, and I'm even more incredibly humbled to be following the Lister Award winner, Dr. Verma, and it was an incredible amount of research productivity. So we're going to scale back a little bit to a smaller population and a very niche population that I'm very interested in clinically. So just as a general introduction to my research program, I investigate clinical outcomes in children with nerve injuries, congenital upper limb differences, and sarcoma requiring microvascular limb reconstruction. And these are the 3 main areas of my clinical practice. I chose today to focus on my research in pain in children with brachial plexus birth injuries, because it's a challenging clinical problem that remains both quite controversial as well as understudied, and it's a very new area of research. And today also happens to coincide with National Pain Awareness Week in Canada, so I thought it was timely. So what is a brachial plexus birth injury? Some of us may remember this from medical school, but as the name would suggest, it's a nerve injury that occurs during the birthing process, typically when a vaginal vertex delivery is complicated by shoulder dystocia. And the incidence of this condition has actually remained relatively static over the last few decades, at 1 to 3 per 1,000 live births, despite advances in prenatal care. And here at SickKids, we see approximately 50 to 70 new referrals per year from all over Ontario, but also neighboring provinces. There are two main patterns of brachial plexus birth injuries that I'm going to refer to today. Upper plexus palsy, or Erb's palsy, which is the term we learned in medical school, which involves injuries to C5 and C6 and possibly C7 as well. And this predominantly affects shoulder and elbow movement, as well as wrist extension, but wrist flexion and finger and hand movement is all normal. And then total plexus palsy, when C8 or both C8 and T1 are also injured, which means that the hand and wrist are affected, and so the child has a completely flail limb. This is our latest algorithm for the serial assessment and management of infants with brachial plexus birth injuries, with approximately 1/3 of children requiring a primary nerve reconstruction during their first year of life. Importantly, though, many of the infants whose spontaneous nerve recovery is too good to require nerve reconstruction do not go on to have a normal limb. And indeed, only those plexus injuries that are fully recovered during the first month of life have no long-term consequences. And these sequelae of brachial plexus birth injuries are what makes these injuries unique relative to adult brachial plexus injuries. So even with so-called milder injuries, these children can develop joint contractures, such as abduction contractures of the shoulder and flexion contractures of the elbow, glenohumeral dysplasia, and limb length discrepancies that alter the biomechanics of movement and alter the quality of movement and certainly the appearance during movement. And after years of intense debate over why these sequelae occur, we now know that the fundamental mechanism leading to contracture development following neonatal nerve injury is improper longitudinal muscle growth due to increased proteasome activity. Another factor that distinguishes brachial plexus birth injuries from later onset brachial plexus injuries is pain. So in older children and adults that suffer a traumatic brachial plexus injury, the development of acute and chronic neuropathic pain, and in severe cases, phantom pain, is one of the major life-altering sequelae. Yet, until about 7 to 8 years ago, it was widely and quite firmly believed that children with brachial plexus birth injuries do not experience pain related to their nerve injury. As recent as 2019, when I was presenting this work at an international conference, a very senior member of the field got up and said, "I've been treating these children for 30 years and they do not have pain." Also in the literature, there is this paper, which has been quoted a lot, declaring that there is no long-term chronic pain in children with brachial plexus birth injuries. Although this was a study of only 24 patients and all but 2 were under the age of 7. So our experience has also suggested that infants and young children with brachial plexus birth injuries lack signs and symptoms of being in pain. But to investigate this further, we performed a retrospective cohort study of postoperative pain following primary nerve reconstruction in 159 infants and found no evidence of a heightened pain response, such as that you can see after treating other nerve injuries. And in fact, most of the nursing reported observational pain scores were 0 during the hospital stay, indicating no pain. And weight-adjusted postoperative opioid requirements were also low and similar between children and with upper and total plexus palsies, and also less than what's been reported for children undergoing other types of surgical procedures in infancy. So there is further work that needs to be done to confirm the absence of pain in younger children. However, what we and other groups began to observe is that older children and teenagers were coming back to clinic describing pain in their affected arm. So in a study in our group, in 65 children with brachial plexus birth injuries aged 6 to 18 years who had nerve reconstruction in infancy, we identified a 25% point prevalence of pain and a 66% lifetime prevalence of pain. Mostly, children described frequent episodic pain of low to moderate intensity, but 8% of this cohort had severe chronic pain. And these findings were in line with emerging data from a couple of other international groups about the existence of pain in children 8 and above. So why do we care about pain in this population? Well, we all probably know a lot about pain in adults, But pain in children also leads to significant physical and psychological suffering for both the child and the family. It has been demonstrated to interfere with functioning, lead to poor school performance, increase the risk of mental health problems, increase clinic visits, and has a tremendous socioeconomic burden. And in one study out of the US, chronic pain in teenagers costs $19.5 billion annually. And of course, there's also been demonstrated that chronic pain in children leads to increased risk of chronic pain in adulthood, therefore leading to a continued cycle of burden to both the individual, the family unit, and of course, society. But from a surgical perspective, we are of course driven to better understand the pain experienced by these children so that we can provide more effective treatments and even evaluate them better for their pain and learn how we might prevent this pain in the future. We therefore went on to perform a larger study to shed further light on the pain experience in older children and adolescents with brachial plexus birth injuries by establishing pain prevalence, determining pain characteristics and pain interference with function, and identifying predictors of pain in this population. And our goal here was to target the full breadth of severity of these injuries, because previously we and others had only looked at the most severely injured patients. So this was a 2-year cross-sectional study utilizing survey methodology, self-report pain assessments, and multivariable regression modeling. So we're very fortunate that Dr. Clark had the foresight 30 years ago to start the Brachial Plexus database, which has a 98.5% consent to inclusion and has basically tracked all of the patients that he has been treating since the late 1990s. So from this database, we were able to identify 684 eligible children that for our survey. But of course, our biggest issue was finding these patients, and for approximately half, we had the wrong contact information. 140 gave no response for unknown reasons, and 4 declined. But this did leave us with 202 respondents to our survey, with a mean age of 15 years, 63% were female, 3/4 had an upper plexus palsy, and 1/3 had a primary nerve operation, which is roughly representative of our population. As one might expect, though, there was a slight bias towards increased injury severity in our survey respondents versus non-respondents, because they were being more actively followed, and thus we had more up-to-date contact information. We then invited any child reporting prior or current pain in AIM-1 to complete an in-depth pain assessment in AIM-2, and there we had very little loss to follow-up. So of the 202 children who completed the survey, 42% reported pain at the time of survey completion on the FACES Pain Scale Revised, which is a validated measure of pain in children. And you can see the distribution of these scores shown here in red. So the majority of children reported mild to moderate pain, but there were some that reported severe pain. And 58% of children also endorsed prior pain in their affected arm. And this is compared to very low rates of pain reported in the unaffected arm. Among the 104 participants who completed the in-depth pain assessment, mean age of self-reported pain onset was approximately 8 years, with 3 children reporting that although they developed pain and experienced pain for approximately 1 year, it then stopped spontaneously after a year. Pain intensity was evaluated using the Adolescent Pediatric Pain Tool Visual Analog Scale, and children reported a mean pain intensity of 40 millimeters with the range of 0 to 80.5. And interestingly, children with total plexus palsies reported significantly higher pain intensity than those with upper plexus palsies, almost double in fact. These are the overlaid pain diagrams for the affected upper limb in all the children with upper plexus palsies on your left and total plexus palsies on your right. And the most common pain location overall was the shoulder, endorsed by 73% of children, followed by the elbow and hand. And as one might expect, children with total plexus palsies reported significantly more hand pain than those with upper plexus palsies, but by contrast, those with upper plexus palsies reported significantly more shoulder pain. This is a word cloud depicting the pain descriptors endorsed by children in this study, and the larger the word, the more frequently it was endorsed. The most common sensory words were stiff, tight, sore, and aching, which are more classic MSK type pain descriptors. The most common evaluative words were uncomfortable and annoying, and the most common temporal words were sometimes and comes and goes. Affective words like terrifying and crying were rarely endorsed by these children. The majority of children use both classic neuropathic and classic musculoskeletal pain descriptors, but the ratio of neuropathic to MSK descriptors was significantly higher in total plexus palsy patients, and again, almost double. Finally, we measured pain interference using the Pediatric Pain Questionnaire. The median and the range for each of the 12 activities are shown here. 81% of children with brachial plexus birth injuries reported that their pain sometimes, often, or always interfered with at least one activity, and the most commonly impacted activities were enjoying the family, seeing friends, sports, and sleeping. Children with total plexus palsies reported more pain interference than those with upper plexus palsies, which makes sense given that they reported greater pain severity overall. We then evaluated predictors of having pain in brachial plexus birth injury, which was based on the initial survey data. We did exclude 2 patients who were advised to have surgery in infancy, but the families declined, so that we had a cleaner cohort. We chose our predictors based on known predictors of pain in adult brachial plexus injury, in other pediatric populations like sex and litigation, and what we also hypothesized to be relevant in brachial plexus birth injury. And these were also data that we had available to us. What we found in this analysis is that any cervical root avulsion at the time of the brachial plexus birth injury was associated with a 2.2 times higher odds of developing pain between the ages of 8 and 19 years. There was also a non-significant increase in pain with increasing age after the age of 8. But this was truly fascinating because here we have a situation where injury severity at birth possibly predicts the onset of pain 8 or more years later. And I will get back to this concept in a moment. So this study was important for several reasons. First, it reconfirmed in the largest cohort thus far that pain following BBPI is real in the 8 to 19-year-olds. And when present, this pain does interfere with function. So while it is mostly intermittent and of mild to moderate intensity, the pain was frequently occurring, and 13.5% of patients experienced severe pain. It was difficult to tease out from the study the contributions of musculoskeletal pain and neuropathic pain, but certainly children with upper versus total plexus palsies appear to differ in their pain characteristics. However, this study also had several limitations, including the response bias, which I touched on earlier, and the lack of a well-validated neuropathic pain tool in children. The APPT and most neuropathic pain instruments used in children have simply been derived from adults, but we know that children use different words to describe their pain and express their experience differently. And this has been a major problem in the broader field of pediatric pain, and I'm thankful to be on the thesis committee of Julia Mezzaroli, who's one of our very bright physiotherapists at Sick Kids on the pain team, who is currently developing such a measure as part of her PhD, and this is going to be quite a game changer for us. Also importantly, we did not have good quality information in our database on biomechanical factors, such as joint contractures and severities of joint dysplasias. And these factors are also very plausibly associated with pain, and they do worsen over time, and particularly during adolescence because of the rapid growth spurt. So we do need to investigate these further. And lastly, we had no data on psychosocial factors that are well known to impact the pain experience in multiple populations. And these also deserve further study. However, one of the most controversial and yet fascinating elements of this story is this concept of delayed onset neuropathic pain following a brachial plexus injury at birth. So we received funding for a small pilot study to investigate whether clinical signs of upper limb neuropathic pain, such as allodynia and hyperalgesia, exist in this population, and how this relates to incomplete sensory recovery proximal to the wrist. So study recruitment has been a little bit delayed by the pandemic, but so far we have 14 patients who completed a detailed assessment by our OT for allodynia, hyperalgesia, and sensation in all peripheral nerve and spinal dermatomal distributions of both their affected and unaffected limbs. These children also complete the APPT at the time of assessment so that we can relate their clinical exam to their self-report pain characteristics. So here are 2 examples of children who have a right-sided brachial plexus birth injury, where we have mapped their self-reported pain distribution in red, the areas of reduced sensation in yellow, and the areas of allodynia in purple. The one on the left has an upper plexus palsy, and the one on the right has a total plexus palsy. And you can see in both of these examples that there is allodynia present in the distribution of pain, but that the areas of allodynia and diminished sensation do not necessarily overlap. Thus far, all of our total plexus participants have allodynia that ranges in severity from 2 to 8 out of 10. The allodynia is in the hand, but also many areas of the upper limb, and is frequently bilateral. By contrast, so far 50% of upper plexus palsy patients have allodynia, which is typically of lower severity and in a more localized distribution outside of the hand. However, the relationships between pain, allodynia, and sensory loss is thus far not clear, and likely we will not be able to answer this within this small pilot study. And in this example of a right-sided total brachial plexus birth injury, there is bilateral allodynia and sensory loss that are roughly symmetrical, but this does not coincide to the self-reported location of pain at the wrist. And yet another example of a patient with a right upper plexus palsy where there is sensory loss and pain, but no allodynia. The bottom line so far from this pilot study, and this coincides with our clinical observation as well, is that a subset of patients with brachial plexus birth injuries have clinical signs of neuropathic pain, which does tend to correlate with their choice of pain descriptors on the APPT. This hypothesis that neuropathic pain can have a delayed onset is supported by a small number of recent experiments in animal models. In a series of 3 studies out of the UK, infant nerve injury was found to result in delayed onset adolescent mechanical allodynia, weight bearing, and cold hypersensitivity in rats. And these authors have also shown that infant nerve injury causes an initial anti-inflammatory response in the dorsal horn, followed by a delayed onset pro-inflammatory response in adolescents that is also accompanied by new sympathetic sprouting in the dorsal horn during adolescence as well. So there may be, in fact, a very clear biological underpinning to what we are observing clinically. One of the things I was really surprised about to find in this pilot study so far, and we were all surprised, is that the majority of participants who underwent a plexus reconstruction during infancy had allodynia in their supraclavicular fossa. Now, in the process of getting down to the brachial plexus, we do encounter those supraclavicular nerves from the cervical plexus, and in children, we have always gone ahead and cut these nerves without thinking twice. Whereas in adults, we preserve or repair as much as possible in order to avoid new numbness. And of course, we fear pain development in adults. And this is true of many areas of nerve surgery in children. But it looks like we might be wrong in our thinking. And at the very least, we now know to ask about supraclavicular allodynia in clinic, and we can address this with desensitization. And I'm also being more mindful intraoperatively now about preserving any large supraclavicular branches where possible. And this phenomenon may also not be unique to infancy. This is just one example of an anecdote, but I've seen this in repeated ways over my short time here at SickKids. And the other day in clinic, I saw a boy who'd been treated by Dr. Ron Zucker, who had a sural nerve harvest at the age of 7. And at the age of 14 years of age, he had the spontaneous onset of hypersensitivity and pain in the sural nerve distribution. And he was adamant, and his family was adamant, that this had never occurred before. And again, suddenly, spontaneously, without new trauma, at 14 years of age, he could not tolerate wearing shoes or socks in the area because of the hypersensitivity in his sural nerve distribution where that nerve had been harvested. When you talk to our pain team and some of the pain specialists, there are also anecdotal reports of chemotherapy-induced neuropathic pain appearing for the first time in adolescence when chemotherapy was administered during early childhood. So this is really interesting. So my hypothesis as it stands now is that there are probably several mechanisms of pain in children with brachial plexus birth injuries. On the one hand, neuropathic pain, which I just discussed, and here I really think that it will be exciting to partner with basic science and translational pain researchers at SickKids to further investigate these mechanisms in animal models. And perhaps in the future, there'll be a way that we can prevent this turning on of neuropathic pain in adolescence. And of course, musculoskeletal pain. And this is where we're preparing a grant now to look at whether joint dysplasias, contractures, and muscle weakness correlate with pain, because these answers to these questions will have immediate actionable relevance to our clinical practice. For example, if we more aggressively treat elbow flexion contractures during childhood, will that help prevent pain in the future? Should we operate in early childhood on severely dysplastic shoulders that function well to prevent risk of pain down the road? Or if deltoid or rotator cuff weakness leads to more pain from overuse later on, should we be trying harder to get better nerve recovery in those muscles using combinations of approaches or more selective nerve transfers so that we aren't relying as much on the traps and the neck muscles to achieve functional movement? And of course, how do psychological factors fit into this? And what is the relationship between neuropathic and MSK pain in this population? It is certainly plausible that a child with BBPI has elbow pain not because of their contractures and stiffness, but because of neuropathic pain emanating from the joint. So at this point, there are way more questions than answers, and it will probably take my entire career or longer to really answer all the questions that we have. But it's a fascinating area that I truly believe will help improve the outcomes for our patients and also has real relevance for the broader field of pediatric pain. So I wanted to thank so many individuals and specifically all the individuals who trained and supported me in research over the years from many surgical disciplines, to my pain team collaborators who taught me a lot about pain in children, to all the students and research personnel who have worked on this project, and specifically to Dr. Forrest, who is our division chief and chair, who has been immensely supportive during my early time as a surgeon scientist. I also want to thank my brachial plexus family, which are pictured here on the left. That's Emily Ho on the left, Dr. Clark, myself, Allison, Anthony, who's one of our therapists, Karen Clark, who's one of our therapists, and Dr. Hopian, who's the orthopedic surgeon on the team. And soon we'll have Dr. Andrea Chan joining us as well from orthopedics. And specifically to Dr. Clark, who's been a huge mentor, not only clinically, but also in research and in life in terms of how to achieve balance. And also I'm incredibly grateful for my amazing family. So on the left, you have a picture pre-pandemic, no masks. This is on the right, a picture during the pandemic where we are well socially isolated up north having a picnic on the lake. So I wanted to thank you very much for your attention and for listening today.
Great. Thank you very much, Kristen, for your outstanding presentation. For the George Armstrong Peters Prize, there's a very rich history of peripheral nerve surgery, as you know, at the University of Toronto with the likes of Alan Hudson. I saw he was on the line as an attendee earlier this morning. Susan McKinnon, with whom you trained, Howard Clark, with whom you work, whom you mentioned, Dimitri Anastakis, and many others. So it's wonderful to see this tradition being carried on by you, and good luck with all of your future studies. So ladies and gentlemen, I think you can see that research and academic productivity are alive and well at the University of Toronto in the Department of Surgery. These presentations should serve as great motivators for all of us to pursue all of our academic goals. Thank you for joining this morning. I'll remind you that next month we have the Robin McLeod Lectureship in Clinical Epidemiology. We'll see you then. And everybody have a great day today. Thanks for joining. See you all.
Bye. Thank you.